my biggest failure will never be for lack of preparation. I think it's more important. So when I go into treatment, I've already done your surgery. I'm now getting a second or third time. What do I mean by that? In this office, we spend a plethora, probably as equal to or more time working on the planning of the treatment than we do actually doing the treatment. Okay. So having said that, I look at the scan, I merge and stitch your mouth scan to the CBCT scan, and I then go into a flight simulator. And I do, think of it as an implant simulator. I do your surgery on the computer. I mean, completely, with the measurements, the angles, everything. I then work with my colleague, Dr. Tadros, Dr. Silva, Dr. Garber, and the laboratory technicians, Sean and David, and we base all of the implant placements on where we envision the teeth are going to be. Because if I place your implants and they're not where the teeth are going to be, it doesn't matter.
Doesn't matter.
Right?
You just got a bunch of screws in your jaw.
Just a bunch of screws in your jaw that they can't use.
Right.
So I need to work with that's why I said, who's your team? I need to work with a team who then can put those teeth that we're going to build, not the ones that are coming out, but the ones that are going to go in. And we need to plan the implants to be placed where the teeth are going to be. So that becomes a big part. The next part is three-dimensionally. We can print a stereolithographic model of your jaw. I can have your jaw in plastic, and I can actually do your surgery on a plastic jaw. So I did it on the computer, I did it on a plastic jaw. I have the teeth that are gonna end up in your mouth, printed and milled here in our own lab. I work with the team that's going to put it in your mouth. And then I walk into the surgery to do your procedure. I've done everything. I would have to fail 3 times. Because I'd have to fail in the diagnostic part, in the planning part. I'd have to fail on the computer. I'd have to fail on the stereolithographic model. And then you would figure, and that's why I say team. When you work with a team, thank goodness the failures are very small. But the reality of it is, I have so many different layers built in to where someone, even if it's not me, can see where the failure may occur. Oh, I see that on the scan. Oh, wait a second, I was drilling on the jaw. I can see where that's going to be a problem. Or the lab guys will say, oh, wait a second, Dr. Salama, if you push the implant in that angle, it's going to put pressure on the zirconia and it could be a fracture point. We need to segregate the implants by a little bit more distance. That's the experience of a team. So each member of the team then sees the layers. Think of it like an onion. You're peeling the layers back. And each person gets a chance to see the failure, see the potential failure before you end up in the operatory, in that chair, and we have the whole team in the surgical theater doing your work.
Right. I respect what you've put together, what you're a part of, and your history. Let me ask you a question. What's your biggest failure? Out of all your dentistry, share with me your biggest failure, if you don't mind.
No, I would tell you, if you're talking about my biggest failure with a patient treatment.
Yeah, why don't we start there?
Biggest failure for me would be I didn't spend enough time looking at the information. The information was there. My biggest failures occurred back in the 90s because I didn't have all this technology, didn't have all this information. So I would assume off of two-dimensional radiography, just panoramic films, PA films, that I could tell what was under the gum, what was under the skin, just by palpation and seeing a two-dimensional film based on experience. That's when you make your errors. So biggest failure I was ever involved in was I was an educator at the University of Pennsylvania. I was a faculty member at the Perrier Clinic. And a patient came in and said, the teeth were broken down. He said, I don't think these teeth are going to be good to support full arch of teeth. So he said, how about can I take them out and we'll then put in implants after she heals? Well, they made this assessment based on two-dimensional radiography. Regular films, dental films that you get every day, and cavities, periodontics, and a panoramic film, something you get for orthodontics. Took the teeth out, let the patient heal. Patient had a denture. They said they were only going to have the denture for a few months and then we'll do the implants. But when the patient came in and they made their incision to place the implants, there wasn't enough bone to place the implants.
Oh no.
So you had to suture her up and put her denture back in her mouth and say, we're really sorry. We didn't know that you aren't going to end up with enough bone because we couldn't see it. We couldn't know beforehand because it was 2-dimensional, not 3-dimensional. We couldn't assess it in its full 3-dimensional, realistic positioning. So what ended up happening is not only a very disappointed patient, but now a patient had to undergo bone grafting, sophisticated bone grafting procedures, had to go for a period of time without their denture so that the bone could heal.
Oh no.
Yes, no teeth at all now. And then after all that heals, then have the implants placed and then have their teeth. And now you're talking about waiting more than a year
Oh yeah.
to receive their teeth, maybe a year and a half. So that would have been the worst failure I was ever involved in.
Yeah.
And maybe the reason I say for me it was the worst failure is because as an educator, I didn't have the information to give the student better information. If I could have seen it beforehand, I would say, we got to be careful here, treating this patient this way and over-promising and under-delivering. Maybe that would have been a patient that today, if I would have known that, I'd say, not enough bone, so maybe we go to the zygoma, the pterygoids. Maybe we go ahead and consider vomer as an anchor source, anterior nasal spine. If we're doing that, we're giving the patient realistic information and they can make that decision.